My name is Pam Havlen. So I'm from the Division of General Internal Medicine, and I'm a primary care physician here at UTMB. I practice over at what we call Victory Lakes Town Center. So it's just slightly south of here between Hobby Lobby and Sports Authority. And actually we have a whole group of primary care physicians, internal medicine specialists there. Today, kind of prevention and screening, and when you go to your doctor and you say, I want a checkup, what does that mean exactly? You know, patients come in to me and they say, I want my physical, I want my checkup, I want everything done, doc. What is everything? You know, how can we meet your expectations, and how can you understand why when we tell you, you can't have that done, you can't have that done, why is it that you can't have that done, and what are the things that you can and should have done? All right. So there must be something the matter with someone who goes to see a doctor when there is nothing the matter. So again, we're going to be talking about what is the definition of a checkup. And keep in mind that mostly, at least what I'm going to be talking about, is people who come in and they're not having any symptoms, they're not having any problems to direct doing any particular test. So when you go in for a checkup, what do you want? You want to stay healthy. You want to prevent disease. You want to catch disease early when it's treatable. You don't want to find something when it's too late. And there's one more, maybe I didn't press it hard enough. You want to feel good, of course. So we try to choose our tests and checkup things to target those things, but what do you not want when you go into a checkup? You don't want to undergo any unnecessary procedures. You don't want to undergo any painful procedures. You don't want to undergo any expensive procedures, and you definitely don't want to sustain any complications of procedures. So again, you know, just focusing on people who aren't having symptoms, we need to target our checkups and screenings so that none of these things happen. So the goals of prevention. There's two main goals when you go in for a checkup. Let's see. One, keep disease from occurring by removing its causes altogether. An example of this would be like a vaccination. Get a flu shot, get a pneumonia shot so that you can prevent those diseases from occurring. The second goal is to detect disease early when it's asymptomatic, when you aren't having any symptoms, and then so that treatment can prevent it from getting any worse. An example of this would be something like a pap smear or a mammogram that you go in, and hopefully if you have breast cancer, you find it when it's small, and simple surgery can prevent it from occurring altogether or from getting worse and you needing chemotherapy and having major complications down the road. So how does a doctor decide what to include in a checkup? How are we being the doctor, we being the medical community, we being all these major organizations that make recommendations as to what should be in a checkup? First is you take into consideration the disease that you're thinking about, the burden of suffering caused by the condition. If we're just talking about a minor illness that's not going to cause anybody in the world any super big problems, you don't need to spend a lot of time looking for that, because even if they get it, there's treatment, it's easy, it's simple. But if it's a major illness that could potentially cause a lot of threat to life and just life in general, obviously you want to be able to screen for that, like breast cancer, these big things that people are really worried about. But also, when we talk about the burden of suffering, you also have to think about how many people is it going to affect. If it's a moderate illness, but it's something that's very common in the population, then you definitely want to spend time looking for that. But if it's a major illness, but is very, very rare, then we don't spend time looking for those things. So you have to think about the burden of suffering, both being the severity of the illness and how many people in the population it's going to affect. You have to think about the quality of the screening test. If there's a screening test, but it picks up a lot of people who don't have a disease, or picks up, but you think that they do, then you don't want to use that. You don't want to use that test. So it's important to think about that. And you have to think about, with the particular disease, if you're screening for it, remember the person doesn't have any symptoms at that point. You're screening for a disease, but the treatment we have for that disease isn't really good anyway. We also don't really screen for that. And also, if it makes no difference whether you pick up the disease early versus late, we also don't screen for that. That's confusing. An example is actually lung cancer. You know, a lot of people who smoke or people who don't smoke are concerned about lung cancer. But they've done studies that have shown that if you do chest x-rays and take samples looking for cancer cells in people's spit, basically, of smokers, that it really, even if you pick up the cancer early versus late, it doesn't affect how long they live or how they live. So therefore, we don't spend time doing chest x-rays and things like that. So these are kind of the things that help us decide what do we include in a checkup. Ask any questions if you have them.
What about family history? Because I would think that would be very important to say, have you had any relatives that have had colon cancer, breast cancer, prostate cancer, whatever, and then say, hey, you're at much higher risk, you ought to check for that.
Right, family history definitely makes a difference. And really, you know, it's hard when you give a talk like this to a group because that's really the individuality of medicine, that we can make it all the science and guidelines that we want, but in the end, it's really just you and your doctor sitting in a room deciding, you know, what is best for you as an individual person. And family history is one of those things that you're right, if people have a family history of something, you might be more likely to do a screening test for that. But again, you have to look at the quality of the screening test as well. So what makes a good screening test? The test has to have what we call a high sensitivity so that it does not miss the few cases of disease present. So that you want to be able to find disease. You don't want to have a screening test that is saying you're fine when really you're not. You want, again, a test that has a high sensitivity early in the disease when you can alter it by some sort of treatment. You also want a screening test that has a high specificity so that you're not finding a lot of people that have disease when really they don't. You want the screening test to just be quick and easy. It just takes a few minutes to perform. You don't want to put somebody through a big procedure. Again, requires minimal preparation from you as the patient. Depends on no special appointments. You want a test that you can just do in the office or during that appointment, or is inexpensive. You also have to think about what is the cost if the test comes back positive and you have to do some follow-up tests. What is the cost involved in that in general? So it's not just the cost of the one test, but the cost of everything that comes down the line. And of course, again, remember, this is for a person who's not having any problems. You want it to be especially safe. You don't want to take somebody who is, feeling fine and having no problems and then cause them some problem because of the test. So tests in this case have to be especially safe. Okay, a bad screening test, this little cartoon, all-night drive-through screening clinic. I'm obliged to inform you, you have the right to remain anxious. Anything you say will be used to further test you. If you do not already have a diagnosis, one will be provided for you. So a bad screening test causes discomfort, causes long-term damage, produces false positive results, tells you that you have a disease when you actually do not. Produces false negative results, tells you you do not have a disease when you actually do. And then this is an interesting one, results in overdiagnosis. As we've become a more health-conscious society and really focusing on trying to prevent disease and looking for disease early, we're finding out that some illnesses actually resolve themselves if you just leave them alone. Or some illnesses have terrible names and are cancers, but actually could go on to, won't go on to cause you any problems. Some examples of this are actually some breast cancers actually can start out and your body actually will take care of it itself. And if we find out early through a mammogram or something like that, that you have one of these tumors, then that signs you up for surgery and all sorts of things, when really if we just hadn't known about it at that early stage, it would have gone away. Your body would have fought it off through its immune system, and you never would have been told you had breast cancer. And it's not just about the treatments and tests that you go through, but it's also when you become a woman that has breast cancer, or a man, some men have breast cancer, that changes your outlook on life. Maybe negative, maybe positive, but it changes it, and maybe we don't need to have put you through that. You might have never known. Another example is prostate cancer. Now seems like it's a cancer that most men, many men will have prostate cancer. I would almost say most men who live into their 80s will have prostate cancer and never even know about it, because it's a cancer that you live with and not one that you die of. And to be diagnosed with prostate cancer not only signs you up for radiation, surgery, and complications from that, but also, again, it changes your outlook on life when now you're a person that has cancer. So we don't want to put a healthy person through these things. So, a modern screening test. This is the screening test we all wish for from Star Trek. You just have a little scanner, you hold it over the body, it tells you everything that's wrong, it tells you what to do, you're done, it's set. Unfortunately, it doesn't exist. So, in today's day and age, a modern screening test is really a discussion that you have with your doctor about those personal things, family history, and also that takes into account where you discuss with your doctor what's appropriate for you to go through. If you're 95 and can't get out of bed, do you really need a mammogram? That you have to decide that for yourself. So a modern screening test calls for shared decision making between you, the patient, and your doctor. You have to decide together, what are the risks and benefits, what are you going to get out of it? You got to weigh the pros and the cons. So that's the modern screening test. Okay, now we get into the meat of maybe what you're all here for. What you need, when you need it, who needs it. The recommendations, at least that I'm going to give, are coming from a group called the United States Preventative Service Task Force. There's a lot of groups, American Cancer Society, American Heart Association, Diabetes Association, various gynecologic associations that give all kinds of recommendations, and sometimes they agree and sometimes they don't. Generally, they're all kind of heading towards the right direction, but these are gonna, at least mine are coming from the U.S. Preventative Service Task Force. They're changing all the time, so what I tell you today may not be true tomorrow, next year. Things that we just said before, things kind of come and go in vogue, so that can be frustrating. And again, remember, if you have symptoms of a disease, that changes everything. If you're having breast pain or blood in your stool or something like that, that changes. It's not a screening test anymore. So again, this is for people who are not having any symptoms. Okay, so preventing cardiovascular disease, including strokes, heart attacks, these are the things that are recommended. And I think you're going to be surprised about a lot of this. There's not a lot of tests that are recommended in general for much of anything, so bear with me. Overall, you have to monitor and treat high blood pressure. Simple, easy to do. You can do it in the office in just a minute, so that definitely meets the criteria of what's a good screening test. Monitor and treat high cholesterol starting at age 20. If the cholesterol is normal, you just check it every 5 years. That's hard even for me as a doctor to just ignore somebody's cholesterol for 5 years, but that truly is the recommendation, that if you have a normal cholesterol at age 20, check it at 25. If it's normal, check it at 30, and so on. If the cholesterol is elevated or you have other risk factors, you have maybe diabetes, you're overweight, you can check it more often. For people who have other risk factors for heart disease, such as maybe a mom or a dad who had a heart attack at a young age, or maybe somebody who's smoking or has other risk factors, they should take low-dose aspirin. But for somebody who doesn't have risk factors for heart disease, then really you don't need to be taking aspirin. They've backed off on those recommendations a lot. This is one that not a lot of people know about or do, but for men ages 65 to 75 who have ever smoked, they can get one time an ultrasound to look for an abdominal aortic aneurysm. Women, not recommended. Older, younger, never smoked, not recommended. So just for that group, you can look for an aneurysm. Quit smoking, have to do that. Maintain a healthy weight and physical activity. Things that are not recommended that most people would think is, I want everything, you know, I want my yearly checkup. They would want an EKG, not recommended. That's a CRP, is a C-reactive protein, stress testing, homocysteine levels. If you're not having symptoms of heart disease, you don't need those things. There we go. Okay, cancer screening. Okay, so colon cancer. If you don't have a family history of colon cancer, your first colonoscopy should be at age 50 and then every 10 years after that. If you have a family history, then your first colonoscopy occurs 10 years younger than whenever the closest person in your family had colon cancer. If your father had colon cancer at age 55, your colonoscopy is age 45. You know, if somebody had colon cancer at age 45, your colonoscopy is at age 35. And then you do it more often, every 5 years. Stop doing colonoscopies at age 85 for people who aren't having any symptoms. And that's just a picture of a nasty looking polyp, actually. Lung cancer. There's actually not a lot of screening for lung cancer. Quit smoking is quit or don't start smoking is the #1 recommendation. Chest x-rays are not recommended, even for heavy smokers. But there has been some new research going on. I think MD Anderson actually has had a study on this. For a highly selected population, which is generally people who've had a long history of smoking, they are starting to think that there may be some use of doing a chest CAT scan. And actually there was they just released some information that suggests it may be heading that way. But at least for right now, not every smoker should have a CAT scan. Come on in. It's okay.
Why the no chest x-rays? Is it the radiation?
Well, the radiation's definitely a risk, but what they found is doing chest x-rays does not help you actually pick at if you pick at the disease earlier, it doesn't save anybody's life. So knowing about it when you're not having symptoms doesn't make any difference from knowing about it when you do have symptoms. Yeah, believe it or not. They did studies, I think, back in the 70s on that. Prostate cancer, controversial. The actual recommendation is showing that the PSA blood test and the digital rectal exam with the finger, neither one has been shown to be useful in saving lives or helping people live better with or without prostate cancer. So the real recommendation is not to do it, but they are saying that a man who wants it done should have a good discussion with their doctor about, you know, the pros and cons of doing it and understand what it means when you get the results back. So at this time, like I said, there's really not screening for prostate cancer because that disease, our understanding of it has changed, and it's really not a bad disease to have. Okay. Diabetes screening. If your blood pressure is high, you should be checked for diabetes. If you're overweight, you should be checked for diabetes. If you're over 45 and have risk factors for diabetes, such as family history, you should be checked. But 25, 30-year-old person who's feeling fine does not need to be checked for diabetes. But so many people in the population have high blood pressure and are overweight these days. We do screen a lot of people. But osteoporosis screening. All women who are over 65 should have their bone density checked. If you are 60 to 64 and you have risk factors for osteoporosis, such as your mom had it, or your sister, or you're a smoker, or Asian people have more incidence of osteoporosis, then you can do a bone density earlier, age 60 to 64. But if your bone density is normal, you should repeat it in 10 to 15 years. Again, that's hard to do, to check it at 65 and wait 10 years. That's hard, but if it's normal, that's the recommendation. So really, women less than 60 who are asymptomatic should not have their bone density checked. If you break a bone from a fall, that's different. Again, you have symptoms now. Screening for various infections. This is a relatively newer recommendation. HIV testing is recommended for all people ages 13 to 64, obviously, particularly if you're at high risk. And that is supposed to be kind of a once-a-year test. That's kind of a newer one. This is also a new one. Hepatitis C testing for all people born between 1945 and 1965. And actually, that's one that's been in the news because I've had several people come in and request just to be tested for hepatitis C because their birthdays fit in those decades.
Now, on that first one, over 64, you don't need to do the HIV.
Correct. Unless you
Yeah.
have a reason to, yeah. But not just for the heck of it. Chlamydia testing for sexually active women ages 15 to 25 and those with behavioral risk factors. We don't test men because men are generally, they're symptomatic. If they have chlamydia, they know it. They have a symptom, whereas women can be walking around asymptomatic with chlamydia, and gonorrhea is less common, so you test for that more in areas where you're seeing that. Okay, immunizations. Flu shot for all people ages 6 months and older, once a year during the flu season. Usually I say October is kind of a good month. You'll see pharmacies start to have it in like August, and really that's too early to get a flu shot because the flu season lasts pretty much through about now in May, and the immunity that you get from the flu shot tends to wane. So October, November, those are usually good months to get your flu shot that'll cover you through the rest of the season. The pneumonia vaccine, or Pneumovax, is for all people with chronic illnesses and for all people ages 65 and older. So if you're younger than 65 and you have diabetes, a chronic illness, you should have a pneumonia shot before you're 65. Or if you have cancer and you're undergoing chemotherapy, you should have a pneumonia shot younger than 65. But for everybody in general, shortly after your 65th birthday, you should have a pneumonia vaccine.
I had a comment on that. My
Sure.
GP told me that after 65, you should have a shot every 5 years.
The actual recommendation is that if you have it after you're 65, it does not need to be repeated, and that's according to the Center for Disease Control. And there are a lot of doctors who will repeat it every 5 or 10 years, but that's not the recommendation because I'm often confused on that because I've had many patients kind of tell me the same thing. But yeah, if you have it after 65, I think there may be, if it's been a very long time and you have a disease like asthma or emphysema and it's been 10, 20 years, maybe you could do another one at that point. You're 85, something like that. But after 65, at 65 one time, if you had it before 65, it should be repeated after 5 years if you were younger than 65. Shingles vaccine is now recommended and approved for people ages 60 and older, whether or not you've ever had shingles. So if you've had shingles once, you can still have the shingles vaccine. If you've never had chickenpox, and that's fairly uncommon in an older population, but there are a few people, and you can do a blood test to figure it out. But if you've never had chickenpox, you don't need the shingles vaccine, but you should probably have the chickenpox vaccine at that point. Regular tetanus and diphtheria vaccine for all adults every 10 years throughout your life. And then the acellular pertussis, or the Tdap, you should have it one time as an adult in place of one of your regular tetanus vaccines. Pertussis is whooping cough, and so it covers whooping cough, which you were vaccinated for as a child, but they start to leave that out of the tetanus vaccine for adults, but we're seeing more cases of whooping cough in adults. It doesn't kill adults, but it can kill children. So in order to prevent the spread to children, adults should be vaccinated.
All right, I think if nothing else, and I'm sure you've learned a lot, you can see how your primary care provider has to be really up to date on all of this information. And I'd like to commend Dr. Havlen and all the primary care providers that we use at UTMB for keeping up to date. It's really not that easy, as you can tell. And I get the easy part of this because I get to move on to talking about cervical cancer screening and breast cancer screening, and that's it, after all Dr. Havlen covered. So let's talk about cervical cancer screening. This is where we do a Pap test. We take a small scraping from the cervix, and we have the option now of doing it as conventional with a spatula or liquid-based, and we're mostly doing liquid-based now. So why do we do cervical cancer screening? Dr. Havlen's been through the criteria of a good screening test. We want to prevent something that's treatable early and that has a big implication if we don't catch it early enough. So cervical cancer is diagnosed in almost 500,000 new cases annually and 240,000 deaths worldwide. In the US alone, we get up to almost 4,100 deaths in 2009 when they did the last big census of that information. Approximately 50% of women with cervix cancer have never had screening, and 10% haven't been screened in the 10 years prior to their diagnosis. So most of the time, these are people who are not coming for regular screening, and therefore their precancerous cells turn into cancerous cells without us seeing that change. So the screening guidelines have just recently changed, and maybe you're aware of this. You're now going into your doctor and they're saying, oh, we don't do pap tests for 3 years. I don't have a laser pointer to show you, but the line you need to see mostly is the 30 to 35-year-olds. We're doing cytology, which is your pap test, every 3 years. Or if we're co-testing with HPV, which tests for the actual virus that causes precancer or cancer of the cervix, human papillomavirus, we can co-test for HPV and the pap test together at a longer length, so every 5 years. So if we're co-testing for the virus and the cytology changes on the cells, it's every 5. Otherwise, your pap is every 3. And so we don't do pap tests on people under 21 anymore. They found that the cervical cancer risk was so low, it wasn't worth the intervention. It wasn't worth the potential interventions that would be required if something was picked up. 21 to 30-year-olds were doing pap tests without the HPV testing. Reason being, a lot of times they're getting HPV and clearing it with their immunological system, and so we're not finding testing for the virus is adding much value. And over 65 years, lucky, we don't need to do any further testing. And anybody who's had a hysterectomy, this used to be a real gray zone. If you've had a previous hysterectomy for benign indications, you've never had a severe precancer or cancer, you no longer need pap test screening anymore after that hysterectomy is done for benign reasons. So these are the individual situations you would talk to your provider about. HPV vaccination is becoming more prevalent. We're hitting a lot of public health initiative, and we're doing a lot of HPV, so actual vaccinations against the virus, which is pretty incredible because there's only a couple situations where we have vaccines which will actually prevent a cancer. And in people who are vaccinated, we're not really yet perfectly clear on what that pap test screening schedule should be. So if you have children or grandchildren who have been vaccinated for HPV, we still stick to this schedule, but maybe eventually we'll do away with the pap test altogether. This does not mean that you should not go and have a pelvic exam with your gynecologist, a well-woman exam, a proper overall health exam, but as far as actually looking for precancer or cancer on the cervix, which is all your pap test is doing, these are the current guidelines. We want to screen more often for people who are at risk, immunosuppressed for some reason, DES exposure, which is a medication that some people noticed that their parents had used or their mom had used, previous precancer in the severe category, CIN 2 or 3, and if you have had previous cancer, even if you've had a hysterectomy, that virus may still cause trouble in the tissues that are left behind after the hysterectomy, so we screen these people for up to 20 years after their hysterectomy. So individual situations need to be considered. We do high-risk HPV testing looking for that virus that causes cervix cancer. We now know there's a direct link, and without the virus, you're not going to get this type of cervix cancer. We want to screen women who have a pap test which is a little bit unclear, and you don't need to know the terminology, but I will go through it with you just so you understand some of the words we use. Women who are postmenopausal with a LSIL, which means a low grade or a mild abnormality, we kind of want to know if that mild abnormality is caused by something else or if the virus is present, which would make us more worried. Co-testing with pap tests in women over 30, like I talked about, that may lengthen the interval which you can delay your next pap test. And we want to know if the virus is there for people who have had abnormalities on their pap test that are a little bit more concerning. So I show you this typically just to help you understand, because when we want to send a phone call back to you or a MyChart message back to you and say your pap test was abnormal, it's not always black and white what the abnormality was. And so I'll try and describe it as a mild abnormality, or it wasn't quite normal, or I'm really concerned you need to come in and talk about this. And so we have ways of categorizing pap test problems, and they come in atypical, and they come in problems with the squamous cells, which are one type of cell on the cervix, and problems with the glandular cells, which are another type on the cervix. Really just for you to understand that when you get a call from somebody, it's not really a matter of always just saying, you know, we had a problem on your Pap test. We may need to do a little more thorough explanation of what that means and how worried we are and if any additional tests need to be done. And I think I need to premise that with saying that if we are worried about your Pap test, it's going to take 5 to 10 years for those cellular changes to occur. So this isn't something that needs to be done really, really urgently. And so if we say, you know, come on back in, you know, in 3 months, or we'll just redo your Pap test next year, you know, if you have any questions, you need to ask those questions. But we're using these guidelines to determine what needs to be done if we do find an abnormality based on what that abnormality is telling us. So I'm going to go a little bit into the diagnosis side just very briefly so that you understand if you have a Pap test problem, what may be done. Cytology is the Pap test. If you have a Pap test problem, we go on to look with a microscope called a colposcope, and we may take a little biopsy of tissue. And I just want you to know that, because if you have someone in your family or someone dear to you, or you have had this issue, it's nothing to be really afraid of. These are the next steps that are going to be involved. So this is a colposcope, that's the microscope over there on your right, and a picture of what various abnormalities on the cervix can look like. A normal cervix, a low grade or mild abnormality, a higher grade, and then cancer, and why we need to look for those things after your Pap test comes back in various abnormal categories. So there's a real cervix, and I always thought it was kind of cool. I used to work in a clinic where we had a video, so when we did the colposcope, you could actually look at your own cervix, which I think is kind of a unique thing to be able to do. So that cervix is entirely normal. The redder part in the middle are those glandular cells I told you about. The pale cells on the outside are the squamous cells I told you about. And really, we're having a good look to make sure that the cervix looks normal under the microscope. And does anybody have any questions about Pap tests? Let's talk about breast cancer screening. Again, these guidelines change, and as Dr. Havlen said, we get recommendations from the American Cancer Society, the U.S. Preventative Service Task Force, and guidelines from the American College of OBGYN, and all three of those, in the case of breast cancer screening, are different. So we kind of pick one of them, and for me, I pick the OBGYN Society for all my guidelines. They put out practice bulletins and help me keep up to date on that. But the guidelines you may hear from other preventative task force and American Cancer Society may be slightly different, and so we can talk about that. But I think if we err always on the side of following a specific screening schedule, we hopefully can't go wrong. So we know that breast cancer is the most common non-cutaneous cancer in the U.S., the second leading cause of cancer death, second only to lung cancer. 50,000 women younger than 50 are diagnosed each year, and the lifetime risk we quote at about 12%, so we say about a 1 in 8 lifetime risk, but that risk is low when you're young and increases as you get older. So screening schedule guidelines kind of reflect that increasing risk as time goes on. There are 3 components to screening. The mammogram is only one of them, the clinical breast exam that your provider is going to do for you, and what we now call breast self-awareness. So we don't necessarily say self-breast exam, but breast self-awareness has taken the place of that because the evidence has been a little bit contradictory as to whether you doing your own breast exams at home is going to make a difference or not, or if it's just going to increase diagnostic testing, and maybe that's not a good screening test according to all the criteria we heard of a screening test. But we haven't gotten rid of breast self-awareness. So let's talk about the mammogram. It's going to detect, just like a good screening test, cancers when they are small and potentially curable. And we call this the sojourn time, when the cancer is detectable but not palpable, and therefore can be picked up on the mammogram, but not by your provider and likely not by you either. The typical ductal adenocarcinoma has a doubling time of 100 days, so pretty impressively, it's going to be present for more than a decade to reach a size that's palpable. So when you go for your annual mammograms, the hope is that you'll detect this before it's actually palpable and when it's curable. Still, mammogram is missing a large portion of breast cancer. What are some other options? So lots of people come in and say, I just want to go straight to the MRI, or I want the ultrasound, or I don't want the radiation associated with mammograms every year. We still recommend mammograms. Maybe that will change, but for now we use mammograms, and if we need to, do another step in testing, we may go to a breast ultrasound, and that's if the mammogram's inconclusive, the breasts are exceptionally dense, and if we needed to guide a biopsy, we may use the ultrasound to make sure we hit the right location, and as an alternative to MRI in high-risk women. So who gets the MRI? High-risk women are basically winning themselves a ticket to an MRI, but we can't do MRIs on everybody. It's cost prohibitive. It also carries risks. So there's injection of contrast material. It takes a long time to do an MRI, and anybody who's laid on a table to have an MRI knows it's not a completely benign screening test. So it's important that we pick and choose who needs to have this additional step in testing. So what can you do? You can have your mammogram, and mammograms currently start at age 40 and can continue annually from age 40 on, and that's according to the American College of OBGYN. Other places might be different. You also want to have breast self-awareness, and this means understanding your family history, understanding your personal risk factors, understanding what your breasts feel like, how they might be changing through the cycle of a month, how they might be changing with menopausal changes, and just having a good understanding of if there was a change, would you pick it up on your own? Also seeing your doctor, you're going to go for your annual well woman exam and a clinical breast exam, and expressing any concerns you might have is really important. Over 40, you want a clinical breast exam with your annual well woman's, and 20 to 39, we suggest that clinical breast exam could probably be spaced out to about every 1 to 3 years. Breasts are very dense, they're very changing regularly on a monthly schedule in that age range, and so it's not quite as important to be screened by a provider every year. So I'm sure all of you have been educated in how to do a self-breast exam, and I think it's not a bad idea to know how to do that, even though the evidence is a little contradictory. But I think a woman generally feels more comfortable if she knows her breasts, knows where the little lumps and bumps are, the dense areas, and how to ask questions if there are concerns of her provider. And I direct you to this website. This is probably one to write down, and this is a breast cancer risk tool. So it's going to go through those risk factors so that you can have breast self-awareness, you can know what your family history is, you can know what your personal risk profile is, and it gives you a percentage lifetime risk. If your percentage lifetime risk is higher than 20%, you win a discussion with your provider about whether you should actually be one of those people that undergoes the MRI testing or the more frequent or more aggressive screening in this case, and you can get that just free off the website. There's several questions, you click them all in, and you get a percentage lifetime risk at the bottom.
I'm back. All right, so here's a list of some various tests that I've had patients ask for, and just these are things that really aren't recommended. Again, if you're not symptomatic, if you're just feeling fine. Carotid artery testing, just check and see if I have any blockage there. It's not recommended. And also the other thing is some of these tests you can go and pay for and get done at churches, and sometimes they have these health fairs that come around. You can have it done, but there isn't really any validity to having those things done if you're asymptomatic. EKG, cardiac stress testing. If you're having chest pain when you exercise, that's different. You should have an EKG and a stress test. But if you're feeling fine, no need to have it done. Testing for peripheral artery disease, checking to see if you have any blockages in your legs, any sort of testing for bladder cancer, ovarian cancer testing, controversial one here, blood test for something called CA-125, and you will hear of various cancer markers that are in the blood. These tests are really only useful for people that are already known to have cancer. If you've had ovarian cancer and you know that when your cancer is back, your CA-125 goes up, then that's a useful thing to follow that woman with. But if you're feeling fine, you don't have any ovarian masses or anything, it's not recommended. It gets a little bit dicey if you tell me your mom had ovarian cancer. Then there's some gray zone there that we can talk about, or that you should talk about with your doctor. Pancreatic cancer testing, there's some tumor markers for that as well. Also not recommended if you are not having symptoms. Prostate cancer testing, we talked about that. Testicular cancer testing, also no screening tests recommended for that, although testicular awareness is probably smart, just as women should be aware of their breasts. Testing for emphysema or COPD, if you're a smoker and you just want to know, do I have emphysema? You just need to quit smoking. That's really what you need to do, is going to be my answer. A well person is a patient that has not been completely worked up. This is what we're trying to avoid. If you walk in well, we want you to walk out well. We don't want to overtest you. We don't want you to overtest yourself. There's a time and a place for testing. We want you to come in well and walk out well. So here's the bad news. You want a good checkup when you go to your doctor? This is what you need. You need to eat healthy. You need to exercise, and you need to quit smoking. I tell all my patients that when it comes to their health, it's only 10% what I do for them, but it is 90% what they do for themselves. And that all this prevention and unfortunately screening and all of that, it all comes down to the lifestyle that you're living at home. It's not about the tests that you get, it's about the work that you've already put in. So it's just so important to eat healthy, exercise, and quit or never start smoking. And that's it. So we'll answer any questions that you have.
So about the diet, like I've heard, is it true that if you need to be careful what kind of meat you eat, this might increase the risk of colon cancer?
Yes, there has been studies that have shown that eating highly processed meats with a lot of nitrates and also meats that have been smoked or charred, that those nitrates and things that build up on the meat do increase the risk of colon cancer. Yeah, and then the other thing that was just in the news, and I haven't followed up checking my medical information on it, is that they're thinking that beef, we all know red meat and heart disease, but what is the reason for that? They're actually thinking that eating a lot of red meat and beef increases inflammation in the body, and that's the reason for the increase in heart disease.
So how much would you recommend people to try a vegan diet?
A vegan diet? Definitely vegan diet is a pretty healthy diet if you can stand it. It's all about that's really an individual decision, but definitely it's a good thing.
I would suggest if you want more of the scientific literature, there's 2 books to read. One's called The China Study, and the other one's called Anti-Cancer. And they'll give you some information about the immunological and inflammatory effects of animal protein versus plant protein, and you can get some of that information for yourself.
I would also like to thank the speakers. They were fabulous. Weren't they fabulous? And we're all going to miss Dr. Havlen, and she's been a very integral part of the lunch bunch, the breakfast club when it was the breakfast club, and my personal physician. She's the best. And I just want to thank her so much.
Yeah, my name's Michael Susan.
We also want everyone to know that we will have this available on the Lunch Bunch website at UTMB and also on the Pelvic Health and Continence Center website. And so you'll be able to link in, refresh your mind about what was presented today, show your friends, get them up to date so they'll know what screening tests to do. And we really want to thank those that provided that, and that was the Oliver Center.
Yes.
And we are very indebted to their support to make this available so that we can go back and look.